Good morning, everyone. Thank you for joining us. My name is Rob Lookstein. It's nice to meet you all virtually. We're here today for another session of Treat Live. We do have a fascinating case that we're going to share with you. I'm joined this morning by a very dear friend and colleague, Sanjay Misra. Sanjay, are you live? Good to see you,
Yes.
my
Yes.
friend. By way of introduction, and some would say Sanjay needs no introduction, but Sanjay is a very, very close friend and colleague joining us from the Mayo Clinic in Rochester, Minnesota. So, Sanjay, thank you so much for joining us this morning. Again, I hope this turns out to be a really fascinating case. I'm going to go to the lab now. We're in room one.
Grass.
Rahul, we
Hey.
are with you.
Yep.
Good morning.
Perfect. Good morning.
And
Can you
I
guys?
know you have a fascinating case. I'm going to hand the virtual microphone over to you.
So just before we start, I want to thank everyone for coming. I want to thank our team here. To my right, I have Dr. Kirema Garcia-Reyes, and I have Toyin Dada, our fellow, and Romita, our medical student. And I want to thank our nurse, our tech, and our anesthesia team as well. Again, we can't do these cases without them. So Toyin, I'm going to throw it over to you to introduce the case.
Sure. All right. Hi, everybody. So today we're going to be talking about an iliocaval reconstruction case. Next slide. So this is a 47-year-old female. She has a history of metastatic urachal mucinous adenocarcinoma. She status post-open excision of the umbilicus and a urachal mass, had a partial cystectomy, small bowel resection, peritoneal implant, and excision in June of this year, with the course complicated by abscess, and she's now status post-washout and mesh explant later in the month. She underwent a cycle of Folfox in early September. However, she began having multiple episodes of abdominal pain. A CT at the time showed a rapidly growing 20-centimeter pelvic mass arising from the right adnexa, which was causing bilateral lower extremity pain and swelling. Lower extremity Doppler was negative for thrombus, but she was noted to have mass effect on the IVC and the iliac veins. So she was admitted for further workup, and we were consulted for further evaluation. Next slide. As we mentioned, her past medical history includes this adenocarcinoma, but she has hyperlipidemia, vertigo, and type 2 diabetes. In addition to her extensive surgery, she's had a history of cholecystectomy earlier this month because of the abdominal pain. No history of allergies, medications for the aforementioned hyperlipidemia, diabetes. Her vitals at the time are pretty much within normal limits. Her exam is significant for lower extremity edema, and she's able to ambulate with assistance. And her labs are pretty much within normal limits as well. Next slide. So we're going to go, this venogram is going to go pretty fast, but I have some stills for you in the next slide. But here we can see that there is compression of the infrarenal IVC and the common iliacs, and then they reconstitute again at the level of the external iliacs, and our common femoral veins are open as well. So I'll let that play through. And then we can go to the next slide. And then here again, infrarenal IVC compression, both on our axial and coronal images on the left and the middle frames, with reconstitution at the level of the external iliac on the right. Next slide. So in summary, this is a 47-year-old female, history of the urachal mucinous adenocarcinoma, status post-resection, with her course complicated by abscess, noted to have this rapidly growing right ovarian mass, causing extrinsic compression on the IVC and the bilateral common iliac veins, which results in symptomatic lower extremity edema. We discussed the treatment plan with patient and she's in agreement, and we are here for planned venogram and iliocaval reconstruction.
Thanks, Toyin. So again, sort of interesting case. So just so everyone knows where we are. So our patient's asleep, so we tend to do some of these cases under general anesthesia, just given her medical condition. We have bilateral common femoral vein access. We have 2 9 French sheaths in both common femoral veins, and then we actually got access above, because you never really know, we're gonna have to do a snare these wires out or externalize them, or if you're gonna need to potentially cross from above. So we just sort of plan for everything, and also we can put a marker on the top to see when we stent as well. We were luckily able to cross without too much difficulty, and then I'll show you the venogram here. So this is from the bilateral common femoral veins. You can see we have 2 wires across the pigtail, and you can see sort of this occlusion of the, let's say, proximal common iliac veins and distal IVC with reconstitution sort of where the pigtail is at here. So again, with all our venous cases, we have a very, very low threshold to the point where we actually do it on every case. We use IVUS for sizing, also to tell us exactly where normal is on either end. So again, I just want to sort of hear your guys' thoughts and what you're thinking. We'll start loading the IVUS up.
Fantastic presentation, and again, a very, very interesting case. Sanjay, I'm going to ask you, Rochester, Minnesota, obviously this is a devastating case, very, very young woman, unfortunately, who's very, very symptomatic in the setting of this, very, very challenging illness. Would you offer this kind of therapy to a, patient such as this? And obviously the issues regarding, general anesthesia and, potentially, complicated interventions. How would you approach a patient that presented like this?
Yeah, great question, and a very exciting, challenging problem for this young female. I think I think there are several things that we would think about. One of them is quality of life and what our wishes are, and then obviously, could we do this safely, and what's her prognosis? So I think it's a balance between those three. If she agreed, we would do the procedure, very similar approach to what Rahul and you guys are doing. I think one of the things that we would think about, and maybe Rob, we could talk about is, what's the post-operative management? How are we going to anticoagulate her? What are we going to use? What's the technology and what, how are we going to follow her? What are the expected outcomes? I know that's a lot of the whole conversation that we'll have, but those are sort of the things that we would think about when we meet her and have this conversation with our oncologists and other physicians.
Maybe 120.
I'll just stop there to get the conversation started.
Yeah, those are excellent points, and I think you've raised a lot of issues here. And I'm going to, kick it over to Rahul and Kirema to say, first and foremost, what was the conversation that was had with the patient regarding
Yeah.
symptomatic relief, long-term durability? That's the sort of I think more clinical question, and then I think from a technical question, if you could just go through in granular detail, what's your setup right now exactly? And, probably just to get us started, if you could go through the IVUS and then tell us, are you anticoagulated right now, given that it looks like you have a complete occlusion of the inferior vena cava?
Yeah. So again, Sanjay, so yeah, we had that conversation with her over the last few days. Uh, she was actually on Lovenox before she came back to the hospital. She basically says that over the last 3 weeks, her leg swelling has gotten progressively worse, and she's got a lot of like hip pain, and she's actually unable to really ambulate. And so she really wants to get some sort of relief. She sort of understands. She's kind of, this is all sort of palliative. She can go back on the Lovenox post procedure again. I think that's a lot of our preference for patients with cancers to do Lovenox. She doesn't actually have a DVT, but I think at least for a short period of time, a Lovenox would be best for her. But I think that's sort of what she's looking for, is to get some pain relief and some swelling relief. It should hopefully last for as long as she's got left.
Perfect.
In
Can you
terms of
walk
the
us through
yeah, in
the
terms of the
IVUS
setup,
right now? Yeah, go ahead.
yeah, of course. So again, so we once we got access and we got across, we did heparinize her. We gave 5,000 heparin. From venous cases, unless they're DVT cases, I don't typically check ACTs because I think we're going to be able to work fairly quickly here. So that's sort of the intraprocedural pharmacy for her. So Kirema, you want to sort of tell us what
Sure.
you see on the IVUS?
So you
there.
can see actually on the floor, we're up to,
So we're basically
We
at the level of the
we can see
pigtail.
the
pigtail,
IVUS,
which is
the IVUS image right now. We are unable to see the fluoro image, so either talk us through where you are, or if there's a way. Now we
Yep.
can see both. We can see the IVUS and the
Perfect.
fluoro image. So it looks like you're in the suprarenal inferior vena cava, if I am correct.
Cor- Correct. Which you can see. You can also see we have a pigtail from above there. And here you can see it's pretty widely open. And if you look at the IVUS images, we're just going to walk it peripherally
We're on the left side.
on the left side. And you can see here it starts significantly narrowing. You can see our other wire. And here, if we stop here, it's a pretty tight spot. And then it's compressed all the way. And here again, we're seeing pretty normal.
Yeah, so you're really
vein.
reconstructing the iliac vein confluence. That's what
Correct.
it looks like, really up to the infrarenal IVC. So, Sanjay, I'm going to ask you. This is, clearly the worst case of non-thrombotic iliac vein compression that you'll see. What would be your, I would say, technique here? There's a couple of different strategies that I think that have been described historically, so-called U-shaped configuration where there's a large implant placed in the IVC, and then iliac limbs, again, sort of like an upside down Y placed in the common iliac veins, or would you do so-called, kissing stents or double barrel stents up to the renal veins?
Yeah, great question, Rob. I was just contemplating exactly what you're asking. I didn't get a side, so I think working backwards, the real critical question is what do we want to make the infrarenal IBC? What is the nominal diameter going to be? If we're using 25 millimeters as our target, then I think you can argue for either Z stents if you're comfortable using them from a jugular approach, and they go up to 30s, and then you could stack them down to the bifurcation, and then put your self-expanding stent of choice into each iliac limb. So that would be one option. If you wanted to do everything from the femoral approach, then I think it's reasonable to bring to do a Y-shaped stent configuration or kissing stents. I think it's a little bit harder to do a bigger stent and then put two little smaller stents inside of it from the femoral approach. If I was going to do that, I'd probably come from above and you use the jugular vein and then stack them and reconstruct the bifurcation. So there's a couple different ways. I would love to see what you guys think the nominal diameter is going to be when you're done, either on the IVUS or the
Yeah,
CT.
on the CT scan, her distal IVC was about 20/21 at the normal portion. Her iliac veins were uh, about 10 to 12, depending on how you measure it, because it's a little bit pancake. So that's kind of what we're going to size for. I think our plan here is to do Y configuration. We're sort of limited. We don't have Z stents here. So we can't really do sort of the bigger Y Z stents. We could probably, we could put a 20 Abre and then try to, you know, go into that from below to make the Y, but that's a bit tricky to do. And then it never quite looks right to me when I do it that way. So
I agree with you, Rahul.
yeah.
Sorry, I think the Y is
Uh,
the easiest, given your puncture points, your
yeah,
access points.
yeah.
Uh,
So we're just pre-dilating here. It's not really a chronic venous occlusion. The left side was a little bit harder to cross than the right, but we're just going to pre-dilate here. I don't know if we necessarily need to, but we're just going to make sure that we don't end up with a pancaked stent when we put them in. So, given the size of the iliacs, the size of the distal IVC, I think what we're planning to do is to do double barrel 14 Abre stents, which are venous stents from Medtronic. We just take them out
Yeah.
here. From Medtronic, because it's kind of what we have.
what's the
There are
range
other
you gonna
stents
do?
currently. I think we're going to try to do just one stent on each side. I think we can get away with a 14 by 150 on both sides. We kind of used, as she was coming down with the IVUS, I sort of put the pigtail basically where it looked like the IVC was relatively normal. It measures about 12, to be honest, 12 to 13. The problem is that if we put a 12, it's going to be probably a little bit short, and then I have to, extend it by 1 or 2 centimeters. So I'm just going to err on being long. We have a lot of runway above. We can go up if we have to go up a centimeter or two to get it.
14 150.
Yeah. So Sanjay, what kind of stents are you guys using for your
Yeah,
IVC?
we have all four. We have Z still left. We sometimes will use wall stents because you can get the 24 millimeter. I know it's very old school, and then we use the Abres or Venova, depending on interventionalist choice. But I think what you're doing makes a lot of sense. Long kissing 14 by 150s. I think it'll look awesome.
So double barrel 14 by 150s, Sanjay, just question, would you have pre-dilated here? And if yes, what diameter? And then what do you think is a reasonable size to post dilate? And what would you take to be a final result to just demonstrate that you're improving the patient's symptoms?
Yeah, it's great questions. So I would have definitely pre-dilated due to the mass effect and the size of the tumor and what I'm seeing on the venogram. I think pre-dilating with 10, 12 is good. And then obviously deploying the stents, completion angiography. I like to see those collaterals gone. I like to see an IVUS and then maybe a pullback gradient. So I would probably do a gradient of less than 1 millimeter mean from the IBC to the external iliac veins on both sides. And then I would do an IVUS, remembering that the venography can be misleading. You can get compression and other things because of the two-dimensional effect of venography and not seeing all the parts of the vein. So I would definitely do an IVUS on both sides before I let her go.
So Rahul, it looks like the length that you've chosen is actually perfect here, and you've got a very good landing zone both centrally and peripherally. This is probably a moot question, but I think it's worth mentioning. Sanjay, do you have any concern about putting an implant over the confluence of the internal iliac vein and the external iliac vein?
Yeah, no, I don't think so. I don't think that's a problem at all. It's an open cell. I think you'll still have good flow. She'll be anticoagulated, like Rahul said on Lovenox. I think there's very little risk to that.
I couldn't agree with you more. I think it's completely safe, and we will, very, very frequently cover the confluence of the internal and external iliac vein when we're doing these reconstructions, regardless of whether it's thrombotic or non-thrombotic. I don't know if you all want to do a venogram just to sort of map it out for everybody who's watching to
Yeah.
look at your landing zones. And I, for one, think you're probably in a really, really good place right now, and this is going to look
Yeah.
perfect.
So obviously, my distal landing zone, I'm not as worried about as I am worried about the top, right? Because I think distal we have length to extend. I kind of want to land them. We could theoretically try to get cute and try to land them into the common iliac veins, but I think just from a durability and length standpoint, it's going to be better just to keep it in the external.
I agree with you
And so
100%. I think
so
I
I'm
think you want it
Same.
do
well
a
anchored in the
yeah
external and common iliac veins, and that's probably more important than the top.
yeah. So I'm gonna push this pigtail. I'm gonna do that run one more time and just push the pigtail down a little bit,
Here.
just so you get a better sense of where we are. But you can see we're still below the renal vein. Um,
Yeah, it looks
yeah,
really good.
and I think we're
That
in
that
a good
looks like a
spot on
great
the
landing
top.
zone. Are
Yeah.
you able to inject around the stents on the bottom just to see how that's gonna end up?
Let me see. I
We
don't
can
know
sure.
these. We
You
can.
want to go lower?
Oh yeah, actually we can. All right, you ready?
Yep.
Now, how good this run's gonna be?
Oh, it's
You can see we're
perfect.
sort of.
Great.
I think
Yeah,
we're in a
I think
good
it looks
spot.
great.
Yeah.
I think it looks
Yep.
great.
So Sanjay, are you doing? So we typically don't do post stent pressure measurements. Like that's a
I gave all the options in case somebody doesn't have IVUS in their lab. I think then you should do post pressure, but since you've got the IVUS, we typically wouldn't. We would do one or the other. Let me just put it that way. The IVUS look great, and
okay.
I
You
think
would.
that
Yeah.
Show us lower.
that's our stopping point.
Yeah. These stents are fairly easy to deploy, right? Like there's sort of the wheel. They don't have sort of the weird idiosyncrasies of the wall stent. Just it's
Yeah.
just a wheel mechanism. We're gonna take those out.
I was just going to say that I think if you're going to do this kind of sophisticated deep venous work, you really need to have intravascular ultrasound. I think that the sort of days when you could eke by and
Can we
not have
get
IVUS, I think are long behind us. There's been numerous
Giselle?
statements and numerous studies that have shown it's leading to improved
Can we
outcomes,
get
improved
212
durability. So
athleticism?
I for one am a very, very strong advocate for the liberal use of intravascular ultrasound. And
Yeah.
I think I can speak for our entire group. We use it for every single, deep venous case, certainly one such as this.
I think the point
Okay.
you're making well taken. If you're going to do these, you got to open up the IVUS and have it ready to go.
Yeah. And we're a little spoiled. We have tableside IVUS, so it's integrated into our room here. There's no point doing a venogram right now. I think we're going to balloon. We're going to use two 12-millimeter high pressure balloons to really slam these open. We hopefully won't have to take it much beyond 12.
I'm not sure that we can see the actual architecture of the stent right now. How well did they open up? Do you feel like you got a lot of luminal gain just after the pre-dill? And I know this is a relatively controversial question that actually looks pretty good.
Does look pretty
do
good. Yeah.
you need to pre-dill and post-dill? I think in this case with such extrinsic compression, you definitely need to
Yeah.
post-dill, but the stent's responding
Yeah.
very well. And I think
It
at
is.
least
You know, the only
from my vantage point, we found these Aubres do very, very well in this iliocaval confluence anatomy. They open up very, very readily.
yeah, I mean, the one thing is we're looking at a 2D image, right? It could be completely pancaked in there,
Of course, of
Um,
course.
Yeah. So here's the 212s going up. Oh, I'm at. So again, we do sort of simultaneous inflation here. I'm at 14.
Who am I?
Yep.
That's just a little less concentrated.
We'll save
The
that.
one thing that I'll say about the double barrel technique that you've very, very skillfully
Yeah.
used here is that it
Doors.
really does make
Good.
the case much more efficient. Not the least of which that you're using just 2 implants here instead of 3. But I
least,
think that the
clarification.
entire setup and the equipment just
Ready?
ergonomically moves much more seamlessly. We've actually published on this. We had a publication just over a year ago in JVS Venous, which was our experience using dedicated venous open cell stents in the iliocaval segment in a double barrel configuration. And at least as far as that publication was concerned, our outcomes were quite favorable. And so unless there's really special circumstances, we've adopted that as our go-to strategy here.
Yeah.
Yeah, no,
So you can
I
see
think that
actually
point-
when we did the. Yeah.
Go ahead,
Sorry,
Rahul.
Sanjay.
Oh.
Yeah, I was saying when we ballooned sort of the place where the stents cross, where it's really crushed, you can see the configuration of the stents definitely changed a little bit. I'll go back to that because I think we saved that. Ready? Hold on.
You're taking these up to 14 atmospheres? Is that what I heard?
So they're. I guess we didn't save it, but they're athletics. So we took them to like 18. We just really tried to slam them open.
Okay.
Yeah, because they're 12 millimeter balloons. I know it's a bit aggressive, but kind of we just do this one again. And
I think it's a very good concept of having a 24 millimeter diameter at the confluence to be able to allow for adequate inflow and then outflow into the infrarenal IVC. So I think 24 makes sense there. I think larger is maybe a little bit too aggressive, but I like the idea of a sort of 24 millimeter diameter there.
I mean, like I said, her iliac's really only measured 12 in the longest dimension, right?
So you're just getting really good wall apposition of the implants, which I think is very, very sound. And I'm hopeful, Rahul and Kirema, that you're going to show us a post IVUS so we can actually glean what the wall apposition and what the configuration of the stents are, whether it really looks like a cylinder or an ellipse. That looks beautiful. That looks really, really nice.
So yes.
IVUS, please.
So I'm going to let Kirema do the IVUS here. So yeah, obviously, as Sanjay said, and I think all of us agree, is that we don't want to get fooled by the IVUS or by the venogram. Look, it's really nice to see that it's very open and that we don't see the collaterals anymore, but we definitely want to see the IVUS to make sure one side's not completely crushed or anything like that,
Okay, we're going to start with our right side.
So we're going to go up on the right side first. Right here, I'll do this for you.
I got you, boy.
Can you guys see the IVUS image?
Yes, we can.
Okay. So here we're coming out of the sheath. So now we're just kind of going to the stent. Here, it's just underfilled, I think. Yeah, there we go. You can see it's very nice and round.
That stent looks perfect.
Very nice and round. A little pancaked, but not totally surprised here. And this is good. Okay, cool.
Right. Perfect.
We'll go up the other side too, just to show it.
Do you want to record that on the way down?
Record it on the way down. Yeah.
I think depending on what the other side looks like, I think that Sanjay's idea of getting pressures is probably a good idea. because there
Yeah, why
is
not?
some deformity of the stents, and while I think it looks
Yeah.
wide open, I think it's just a good, concept to make sure that there's no gradient after this reconstruction. It would be a huge disservice to the patient to leave her with
Yeah.
a persistent gradient. And you're obviously set up to do it because you have access above the, conduit that you've
Gonna go right
created
back.
and immediately
Gonna go live.
below it. So I think you're set up for a pretty easy pressure setup.
So this was the side that was a little harder to cross and had a more significant stenosis. So let's see, going into the stent,
Right. Pancake, but it looks pretty good.
this was the area. Actually, that looks pretty good.
Yeah. Left side actually looks really good. We got
Yeah,
good
I
wall
I
position as
think
well. So
I think the confluence
good.
looks great. So I for one, I
Yeah.
would recommend that you just measure a gradient per Sanjay's recommendation and use that to guide whether or not you need to do any further work here.
Yeah. For sure. We can set up the pressure
Oops.
manifold. Melissa, can we
No,
set up a pressure manifold? The pressure?
let's look up for pressure.
No, the
Yeah.
pressure to measure pressures. So I guess the question that comes up sometimes with these, no, it's okay. With these patients with the external compression, what do you guys do, or what's your recommendation if there's still too much external compression? Would you guys put a balloon expandable stent, or if you don't have enough radial force with your self-expanding stent?
Yeah, no, great question, Rahul. That was just what I was
Wanna-
going to ask you or Rob. But I think, if you've got a gradient, and again, you've got to sort of have a number in mind, I would definitely put a balloon expandable stent in, something that's got some radial force. I like the LD Expresses in the iliac
We
sizes, so the
changed the
12
scale
millimeters.
down.
But you need something in there, I think, to prop it open. I think it looks very good. I think the right side maybe pancaked a little more than the left, if I understood the pictures correctly. But I think the left side where you had the trouble looks, I think both sides look good, and I think you're going to have a pretty good gradient. What do you think, Rob? Would you go in there
So
with an expandable stent?
I have not been successful. That's probably the right word. I've not been successful utilizing balloon expandable stents in the central veins. And it just could be my lack of experience here. And so my sort of reflexive answer would be to use a larger balloon to dilate it. And if that is unsuccessful, to reinforce it with a second open cell self-expanding stent to try and increase the outward force. And again, that's just my own anecdotal experience. I've probably done a handful of cases where we've relined or double reinforced, a couple of these cases with really dense extrinsic pressure, and they
16 to
just all
15.
happen to
Yeah.
be oncologic cases. And with a, second lining of the stent, it tends to open up. It is not routine that I've seen that, but every once in a while. And so there's a persistent problem, I'll use a larger balloon to dilate it, and then again, the sort of bailout situation, I'll just reline it again, and almost always that sort of takes it out of it. But this is, probably a 1% incidence out of the hundreds, if not thousands, of cases like this that we've done.
So I don't know if you guys could see the pressure. So on the right, from the right common femoral vein, we got a pressure of about 16. The IVC is about 15, and
Yeah,
on the
that's great.
left, yeah, we're getting. I don't think that's right.
Yeah, me either.
I'm gonna flash it.
For the audience, one is what you want to see as a gradient.
Yeah, on the left, we're getting actually a lower pressure, so I'm not even sure what's there, but
Oh, there
it's,
we go.
yeah, we get about a pressure of about 13 on the left, which 12, 13.
You
So
wanna
Real
repeat the
right.
IVC there just to make sure that you're correlating?
yeah, Mhm. Yeah, we're getting a good waveform on the from the IVC standpoint. Yeah,
Yeah, I
Yeah.
mean there's clearly no
yeah,
gradient at all. It
Yeah.
looks really,
yeah,
really good. So, really fantastic work. I'm really glad that we did the
yeah,
gradient and the IVUS. I think that really, really thoroughly shows that the patient has been decompressed. So, really, really nice work.
yeah,
If we could talk for a little bit while we're, winding
sure.
down, what would be your recommendations? And, Sanjay, I want to open this up to you about, what would be anticoagulation and or antiplatelet therapy to get this patient out of the hospital? And then how would you follow the patient up in your outpatient office hours to make sure that they have the greatest likelihood of long-term symptomatic relief? Sanjay, I'll start with you and then probably go back to Rahul because I think he's going to be seeing this patient in follow-up.
Yeah, so I like Rahul, your idea about Lovenox. I think that's a perfect strategy. Whether that be BID or once a day would be one thing to think about, and making sure that she's adequately dosed. I think some of the DOACs, especially with the higher weights, can be a failure. I think the Coumadin has its own challenges of regulating the INR if you were to do that. So I think that's one thing. I don't know that I would put her on another antiplatelet agent. I would start with that, but I definitely, since you didn't have a DVT, I'd see her back at 1 month with an ultrasound of her IVCs and iliac veins, and then monitor her with that. In the first year, see her based on the 1 month. If it looks good, it'd be either come back in 6 months or 12 months, and then annual visits with ultrasound and go from there. The other question, sorry, Rob, is how long would you leave her on anticoagulation? I think that's a little bit harder to answer, and whether you'd convert it to dual antiplatelet therapy after a month. I don't have a good feel for that. I'd like to leave them on some kind of clopidogrel and baby aspirin, maybe after a month. But I'd like to hear what you guys do.
So I'm just watching the screen here. Rahul, do you think you need a extension on that side?
I do. I don't understand what happened, but it's definitely
Well, what could certainly happen is you could see that the extrinsic compression on those retroperitoneal structures shifted downward with the stent, and so you could have now an extrinsic compression on that external iliac vein. And so, we've certainly seen that
1480, yeah.
before.
Yeah.
The tumor is not fixed. The
Right.
external iliac vein is obviously not fixed. And so you can have, things shift after you've reconstructed the common iliac vein. So I think that, this is just a very good teaching point. I'm glad we didn't end it so,
You
quickly.
need them on the other side too.
You might need you
we need one
might
on the
need
other.
bilateral extensions actually.
Correct.
Yeah, 2 of them. Yeah.
So
Actually, can you be
just
1480
from
and a 1400? No, stent.
yeah,
Stent.
Aberration.
yeah, I was going to say what kind of length are you thinking of here?
So it looks like a little bit longer on the left. So I think, again, I know people don't like it, but I tend to eyeball it. But it looks like about an 60 to 80, somewhere there. You want a good decent overlap. And then the other side looks a little bit longer. So hence
Got it.
180, Yeah.
Can
That's how
also
it came
be
up.
I think you're going to have to
with
back
that.
out the sheets in order to get, a good landing zone,
Yeah.
probably in the, probably the most
Okay.
central portion of the common femoral veins.
Give me the 100 first.
Yeah. No, I agree. Yeah.
So this is, I think it's a good teaching point about, how if your sheets are, almost in your stent column, that you can miss an inflow lesion that's either surrounding the sheath or distal to the sheath. And, this is probably one of the major pitfalls of doing thrombotic iliac vein reconstructions, is that you might not have adequate inflow around your sheath. Your sheath might be, physically in your stent once you've done your reconstruction. And so the outflow looks perfect, but you haven't adequately identified your inflow. It's one of the, reasons why some people advocate for doing a lot of these cases from a popliteal vein access. I would have not recommended that in this case. I think that, doing common femoral vein, given that the entire inflow was normal. And again, here you're clearly able to map out where your landing zone's going to be. So I think this is the right way to approach it. And Rahul, just so that we're sharing the technique with the audience, did you choose the same implant, or did you go to a different architecture here? What did you choose?
Same implant. Yeah.
Okay.
Same implants. We did 14s again. Again, we don't necessarily need to take it to 12, but I think we probably will, maybe just gently as opposed to going up to high pressure.
Got it.
You can do yours. Just we'll do it one at a time here.
Shut up a little bit. Yep.
Yeah. There you go.
And then probably the most important technical point,
Attention.
which
Okay.
I know that you all know in the lab, is that you have to be very cognizant that your common femoral vein sheets don't advance through the newly deployed stents and disrupt the architecture. So you need to be very, very careful
You're good.
when you're doing the exchanges, when you're removing the stent catheter, and when you're reintroducing the post-dilatation balloon, that you don't disrupt the architecture of the stents. Otherwise, you're going to end up with something that's might not be favorable.
Yeah. Actually, one
And
case I
that's
think
fun
we may
points.
be
You
able
have
to
to
get.
be careful you don't snag the other stents as you're making all
Yeah,
these
I mean the other thing is
exchanges.
also when. Yeah, I guess didn't really pause when we
Pause.
put the wires back up, but what we did is I actually took a Berenstein and just sent it naked, so it just sort of like doubled over. It caught the edge of the stent, doubled over, and just went up. So I knew it wasn't in the through and through a strut, because that's the other thing you don't want to
That's
cage.
another pitfall. Absolutely. So it's great that you mentioned that. That looks a
Yeah,
million
actually, that's
times
way better.
better.
I don't think we need to.
Better. Yeah.
Ibis.
Yeah, so we'll IVUS it one more time just for completion's
Great,
sake. But
thank you.
yeah, I don't know if I need to necessarily balloon it because I think here it's more of just a shift as opposed to like
I agree, but I mean, we can look at
Yeah,
the
we'll IVUS
IVUS
it. Yeah.
and then
Yeah.
and then take it from there.
Yeah.
And then this side.
Yeah.
Again, really good
Yeah,
teaching point here about really make sure that your inflow's adequate. And sometimes if your sheath shows that the venogram's perfect, it could mask a inflow problem, as was the case here.
Ooh, that
So
was nice.
just really
Yeah,
nice
so here's the
example
right
of
side.
that.
So yeah.
Yeah, very
See the
different
IVUS?
now. Very different.
Yeah.
Really great
Yeah.
teaching points now about IVUS, and you clearly see the difference between what we had, just a few moments ago and
Yeah.
what we had now. So radical difference.
Yeah. Yeah, I mean we before we put the second stents in, I think we saw a little bit weirdness in the external iliac. We kind of chalked it up to maybe the wire. But once we pulled the wire and did the run again, you could clearly see there was something going on
That way.
down there. But it looks like we got good wall position, so I don't feel like the need to at least balloon on the right side. We'll check the left side because it looks fairly open and round. So the other things we'll do for her is we'll start her on Lovenox post procedure once she's hemostatic from all of the accesses and stuff. We'll probably put her on TEDHOs and SCDs as well, just to help with the flow. Just be careful. To help with the flow and everything. Something we sort of carried over from DBT, but I think it's helpful.
Rahul, what are you thinking about length of treatment? Will you keep her on the Lovenox?
I'm gonna leave that up to our oncologist. Can we go live? There we are.
That looks
See,
great.
here's the other side. Yeah.
Yeah, that looks perfect.
Wall positioned. Yeah.
Yeah, you have very uniform wall up position there. So that's very, very nice.
Cool.
Excellent.
Yeah.
So
Perfect.
a really great result, guys, and a lot of teaching points in this case. So really, really good conversation. I'm gonna throw out a sort of ninth inning controversial question. Rahul, what do you think the role is, if any, for either drug-eluting stents in this application or covered stents in this application? And do you have any insight or experience using those technologies? I think venous stent in general is probably ripe for a little bit of innovation right now, but I'm just curious. And then I have a follow-up question for our friend Dr. Misra to follow that.
So in terms of anti-proliferative, I mean, obviously Sanjay knows way more about that stuff than I do, but I think here in this specific case, I don't know if anti-proliferative is going to help her because it's not really an occlusion. I'm not really worried about fibrosis of the vein. Like if she clots, then maybe we have the right size balloons. We have 12 millimeter, which we use for dialysis work, which is sort of approved for that. Obviously, very very off-label in that situation, but in external compression, I'm not sure if anti-proliferative is going to be very helpful. There are obviously no drug-eluting stents that are the right size for this. We have used drug-coated balloons sort of as a last-ditch effort. We're going to take these sheaths out. Yeah, you want to take them out? As sort of a last-ditch effort, if we don't know why it's going down, to maybe try to help do that. I haven't personally noticed any difference in that sense. Covered stents, I know in dialysis, again, there is data to show that covered stents do have better patency in sort of the bigger vein. But again, what size? We would need 14 millimeter covered stents, so I have to put endografts, and so that's sort of where we're kind of stuck, right? Sanjay, what his thoughts are on that one too.
Sanjay, I'm going to ask you, the same question, but also, for those of you that aren't aware, Sanjay's one of the preeminent global researchers with the use of stem cells as therapeutics for vascular pathology. And so, Sanjay, if you were to give us a glimpse into the future based on your insights and your experience with your own lab and your own research, and obviously the center that you've built at Mayo Clinic, where do you think the potential applications are for disruption for these kinds of complex, venous patients where they have such severe symptoms to give them the greatest possibility for long-term symptom relief?
Thanks, Rob. These are very provocative questions. I think one is, who would be the patients that would need this therapy? We know that iliac vein stents do very well in the right population. Non-thrombotic stenotic patients do very well and have really long patency and symptom-free survival. In my own practice, I have May Thurner patients who've made it through a decade without a reintervention. And so I think one is identifying the patient subsets that fail. And those are going to be the thrombotic patients with coagulation disorders. And then I think the question is, what are the therapies around the corner that are available to us, and would they be the right ones, whether they're the antiproliferatives, the paclitaxel, and the limus-coated technologies, recognizing that we don't have the diameters we need, but those are the most closest to us for translation. The covered technologies, I think, with PTFE prosthesis are interesting. Those are sizes and other considerations, as Rahul elegantly put. And then I think there's going to be biologics that are going to come, whether there's biotherapeutics that are anti-inflammatory, such as stem cells. I think those are going to be down the road 5 years, 3 to 5 years. We've already developed them, and now it's sort of delivering them. We've done this experimentally for dialysis fistulas, MSC therapy. So they are very anti-inflammatory. So, and there'd be a potential application would be around how do you deliver them, that endoluminal, periadventitial, and some other things. But those are what's on the frontier of what I see in medicine right now. And the last point I'll make, I think it's very critically important for us as a specialty to be involved. We have the catheter skills, we have the tools, and now it's just a cellular drug therapy delivery problem. And we have technology, bullfrogs and other technologies in our hands that we can use, because we've got imaging, we've got intravascular approaches, we've got IVUS, we've got cross-sectional imaging, we've got everything in our hands to really move this forward. I'll just stop there.
No, it's great insight. Again, I always appreciate your glimpses into the future. I really do believe the field will, move in that direction for the next several years. Rahul, I'm going to give the mic back to you, and Kirema, closing thoughts on this case.
Yeah, it went. I think it went very smoothly. Again, to thank everyone for joining us on the web, and obviously thank everyone in the room for helping us get through this case. Also want to thank our sponsors as well for helping us support these cases. We can't do it without them.
Thank you, Rahul. Kirema, Toyin, fantastic
Thank-
work, great presentation. Really appreciate the professionalism and the ability to obviously shift and bring a fantastic teaching case for all of us to learn from today. And we'll see you all again next month. Have a great day and a great weekend.